Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Thank you so much for joining. This is, as always, your opportunity every Tuesday morning at 11 to get your questions about public health in Chicago answered. Most of what we continue to talk about is related to infectious diseases, with COVID-19, of course, being what still is the questions we get the most of. Right now, we also have continued to get a lot of questions related to monkeypox. But as you know, we've been working to also expand this conversation and many weeks bringing in guests to talk about a lot of other work that the health department does. So today, we are going to stay primarily focused on some infectious disease related updates, but I wanted to give you a preview of what we're planning to do over the next 2 weeks. So as some of you know, Mayor Lightfoot introduced the budget proposal yesterday for the city of Chicago. And always the budget period is a busy time for the health department, for the aldermen, for the city. And my plan is next week, next Tuesday, which would be the 11th, we're actually going to do a little bit of a budget conversation about some of the new investments that are being made in Chicago Department of Public Health programming, answer some of your questions about our investments in the non-infectious disease space. This is a good opportunity if you have questions about mental health, for example, substance use, the violence prevention interventions. If you want to learn more about how we are working to hopefully get to a point where every baby born in the city of Chicago, in any of our 15 birthing hospitals, every baby and their family are offered a free at-home nurse visit to make sure that mom and baby are connected to care, but also in what we call Family Connects, that any other needs, mental health, resources, physical health, but also things like, are there older kids who want to be enrolled in preschool? Does the home potentially need some assistance with lead paint cleanup, that sort of thing? It's called Family Connects, and it's one of the new things that with the American Rescue Plan funding, we have been growing. And so anyway, next week, we will, I may potentially bring in actually one of our budget folks from the health department, but we'll be really doing a focus on budget and CDPH. So think ahead, come with your questions there. My goal, as always, is to be transparent about where we are growing programs, how we are spending funds, where those funds come from, given that most of them continue to be direct federal funds, and then what we do with that funding. So that's what we've decided to do next week. And then the week after, which would be the 18th, excuse me, we're planning to do an environmental focused update. That's an area we continue to get questions about, and I want to really have a focused opportunity again to answer your questions about what the health department does in the protecting human health and the environment, and many of the new things and ways we're sort of growing there. So always, we will continue to bring updates on infectious diseases, let you know what's happening with COVID boosters, et cetera. But that's what we're planning for the next couple of weeks. So as always, you can put your questions directly into the box below. You can use the hashtag AskDrArwady on either Facebook or Twitter. We'll spend the first half or so of our time going over some of our data and our public dashboards, doing some slides so you know what's happening here in Chicago, and then, as always, we'll take your questions directly. So let's start with our data. We'll start with COVID. Chi.gov/COVID-Vax will get you to the overall vaccine page. You can also get to COVID-Dash, chi.gov/COVID-Dash, to get right to our dashboard here. And again, you're seeing just about everything on this dashboard is green. We're averaging under 300 cases a day diagnosed across Chicago. Remember that these are only cases that are diagnosed in laboratory settings, people who are getting diagnosed in an emergency department, in a hospital, at the doctor's office, at a pharmacy, at a walk-in laboratory. And so it's only a fraction of all of the testing that is done in Chicago, given that a lot of the testing is at home. But we have, we know as these testing patterns change, we are able to adjust and understand, what's happening with COVID. And so we definitely, have continued to see drop in those new infections. And of course, those are people who also tend to be more acutely ill, people who are seeking medical care to get testing. Along with that, just as we have since the very beginning of the COVID outbreak, we monitor hospitalizations that are much less dependent on changes in testing patterns. These are people with a current COVID diagnosis who are hospitalized in Chicago hospitals. And you see, we're averaging now about 25 Chicagoans a day being hospitalized. And that is, if you look at the graph in the middle and the top row there, you know, that is a little better than we were. It's certainly way better than we were in any of the peaks. And it's the combination of those cases and hospitalization rates, as well as the hospital beds in use. About 3.4% of all of our hospital beds right now across Chicago are taken up with patients with a current COVID diagnosis. Those are the metrics that help us define our COVID community level, which thankfully is low right now in Chicago and across Cook. You'll note we're still averaging between 0 and 1 deaths a day, a little bit under 0.5 every day. So that's around 3 deaths a week in Chicagoans. So very much not gone, but in good control at the moment. The vaccines administered, you can see, and just remember, you can click on any of these. So like if I want to get a better look at what's happening with vaccines over the whole pandemic, you see this big spike that happened right in early September. That was when the new updated booster became available. Remember that this fall marked the first update to the COVID-19 vaccine. So all of the vaccinations prior to this in adults and kids were all patterned around protecting against the original strain of COVID-19 before we had all of these variants emerge. Really exciting technology now means that for the first time, the updated vaccine that people are getting in the fall of 2022 is not only giving you a boost against all of the COVID we've seen to date, but it is providing more specific protection for the Omicron subvariants that are circulating right now. So was pleased to see that nice sharp uptake. It's actually the sharpest, the quickest rise, if you look back, that we've ever had in vaccinations, partly because there was good supply. And then it's, you know, we've doing 6,000 a day or so across the city is quite good. We've seen that drop even a little bit. Still 5,000 a day is quite good. But given that more than 80% of Chicagoans should be getting this vaccine, we have a very long way to go. And certainly we'll take your questions that you have related to the COVID vaccine. I also just wanted to show you, if you go to chicago.gov, just COVID Vax, we continue to try to keep this up to date. And so if you want to understand more about the most recent booster, you can click here. We've got lots of different resources here. Under our FAQs, you can come here, you know, what do I do if I lose my vaccine card? There's your answer. There's your click. You know, does it cost anything to get the vaccine? What do we know about Novavax? What about the questions related to children and teens? What about your more general questions about COVID? What about vaccine safety? A lot of the questions that people often send in case we don't get to them, you can find on this page. And if you want to just understand more about our in-home vaccination programs, our booster dose programs, what we're doing for children and teens, what's happening with vaccine providers, Chicago-specific news, this is a really easy place to come and get it. And then you're able, up at the top here, to explore what we're doing in the equity front, what we're doing with data. So know that we are working hard to try to keep this as up to date as we can. And if you have suggestions or thoughts about other information that you think we should be providing, we're happy to do that. On the monkeypox front, chicago.gov/MPV or chicago.gov/monkeypox, you know, right up at the top, we've got the call numbers that you can call if you have questions. But similarly, we have data about, you know, what are the risk factors? What about prevention? What are signs and symptoms? We have information about treatment, frequently asked questions, lots of things that you can share or use yourself if you're wanting to get the news out about monkeypox. And then, of course, our data dashboard for MPV. which I'll just let it load a second. We also are updating this 5 days a week, just like we are for COVID. And you can see that numbers in terms of new COVID diagnoses are down, but they're not down to zero, and we don't anticipate they're going to be down to zero. I think that MPV is probably here with us in an indefinite way, and it is important that folks who are eligible get their vaccine. You see the MPV vaccine data here. We've done almost 40,000 doses, which is good. Reminder that everybody who gets a first dose of MPV vaccine should get a second dose more than 28 days later. The blue are people who have gotten that first dose. The red are people who have gotten the second dose. So you're welcome to explore any more about that you'd like. All right, I'm going to go ahead and turn just to the quick update here. On the MPV front first, and actually before even the MPV front, a few of you wrote in with questions about what's happening with Ebola. So some of you know that Ebola is a disease that I personally have spent quite a lot of time working on. During the last big Ebola outbreak in West Africa, I was working for the CDC at that point, though assigned to the Illinois Department of Public Health, and had the opportunity to deploy as part of the CDC teams to Liberia at a couple of different points in that outbreak, and then spent a lot of time here in Illinois and in Chicago with partners doing our Ebola planning, working with the hospitals to make sure we have the ability to take care of Ebola. So every time there is an outbreak of an infectious disease, really anywhere in the world, the health department knows about it. We get some information, we do some preparedness and planning. I do not have a high expectation at all that we would see Ebola cases here, but it is important that we are prepared, given how connected the world is. And so just for a quick situation report, a number of you had questions. On September 20, Uganda did declare an outbreak, not just of Ebola, but this rare Ebola Sudan strain. And that's different than the strains. We've all learned more about variants and strains and how what can work for one variant or strain on COVID or flu might not work for another. It's also true for Ebola. And so the recent Ebola outbreaks that we've seen, including the larger outbreak back in 2014, that was a different strain. And so as of just the 27th, there had been about 31 cases. About a third of those folks have died. Ebola has a really quite serious mortality rate. So even when numbers are low, we're concerned. There have been some cases, but I want you to know that the WHO, the CDC, regional and global risk assessment for this remains low. All travelers are being screened at international departure from Uganda, for example, if they're coming to the U.S. There's only about 140 travelers from Uganda who come into the U.S. each day. The main four airports are JFK, Washington, D.C., Chicago, O'Hare specifically, and then Atlanta. So there's no needed recommending of incoming travelers. Also, we've stopped right now bringing in inbound persons from refugee camps in Uganda, just making sure that this is under control. So we're watching what's happening internationally, certainly pushing hard to make sure that the resources are on the ground so that Uganda and that area can contain this outbreak. But locally here, I want you to know that our teams with hospitals and healthcare partners across Chicago, we have strong healthcare coordination and preparedness. We have excellent infection control competencies. We have 3 hospitals ready right now to evaluate and treat, including pediatric capacity. And I want to really give a shout out to Rush, to Northwestern, and to Lurie Children's, all of whom have led in our preparedness and resource sharing in the very unlikely case we were to have an example of this in a traveler. And we've met with those organizations. We've met with other hospitals. I think the challenge is that as of right now, testing for this particular strain is actually only available at 6 laboratories in the U.S. So the CDC is working hard to quickly increase some of the capacity for testing. You've seen that it's a challenge when testing for an emerging anything. If we don't have access to testing, that's an issue. So CDPH would work with the state, would work with IDPH. We would coordinate submission to the lab in Michigan, which is currently the nearest laboratory in the chance we had to evaluate somebody. And we really, a gap that we continue to work to build here is that not for individuals who are themselves travelers who might be need to be tested for potential Ebola, we have all the ability to safely isolate them in a hospital setting. But where you think about people who they're traveling with, we want to make sure that the families also, in case somebody were to be diagnosed with Ebola, it's important that the quarantine, where people are not sick, but we want to monitor them very closely, because if a family member were diagnosed, we would need to be following them. So we're working, again, sort of with the state and identifying what that would look like. So that just, I wanted to give you a high level. This is the kind of behind the scenes preparedness work that we do. I am not highly concerned at all about this Ebola outbreak, but our team at CDPH, no matter what, when there is an outbreak of something around the world, we are a very globally connected city, and we do a lot of work to make sure that we are as ready as we can be. So we'll let you know if there's anything more to be concerned about there, but we're on it. It's in that little area up in the upper right there, that brown area in Uganda. It's not at this point in the capital, Kampala. If we do start to see cases in Kampala, that would increase everybody's risk or everybody's concern about potential spread. But overall, low level of concern, but we are in a preparedness mode for it. All right, quickly on monkeypox. That outbreak also continues to grow internationally. We've now had cases in 106 countries. You've heard me say this before, but one of the reasons we are highly unlikely to eradicate monkeypox or get to a point where cases are vanishingly small again is that while the U.S. at this point has access to vaccine, has access to treatment, that is not true in most of the world. And again, we travel as a society, and that remains just a concern of mine. In the U.S. overall, we've now had more than 26,000 cases, 1,300 of which have been in Illinois. More than 1,000 of those have been in Chicago. And across Illinois and Chicago, we've had cases, on the left in multiple counties now, as is pretty much always the case for emerging infectious diseases. Large cities is where these tend to emerge. It's where the travelers often come into if this is spread internationally. It's where the density is higher. It's where we have often more of the diagnostic capacity, the hospitals, the academic providers who are studying and watching for these diseases. So not surprising, and I'm really pleased actually with the containment work that we've done in Chicago to date. But we have seen cases across the whole city. Monkeypox cases nationally, as reported to CDC, are downtrending, as you see in this graph here, and that's good news, just like they are in Chicago. But we've had no deaths and about 67 people hospitalized, though, with MPV. And week after week, we are seeing an increasing proportion of MPV cases among Black non-Latinx Chicagoans, in purple there. So at the beginning, most cases were in white non-Latinx and Asian Chicagoans, with a smaller number in Latino Chicagoans and really quite a small number in Black Chicagoans. And the demographics continue to shift. And so it's especially important that Black and Latino residents at risk get vaccinated because demographically, those are some of the areas we continue to see growth. This, again, is all publicly on the website, but I just want to highlight that at this point, MPV overall is looking more like the city in terms of the race and ethnicity demographics, you can see about 37% of our cases have been in white non-Latinx Chicagoans. Still, that's a little bit higher than the percentage of white non-Latinx Chicagoans overall, about 30% in Latinx Chicagoans and 28% in Black non-Latinx Chicagoans. It's just that the growth is higher right now, especially in Black non-Latinx Chicagoans. Still, 93% of Chicagoans who have been diagnosed with MPV report their sexual orientation to be gay or bisexual. I shared the vaccination numbers already, and I want to remind you that the MPV vaccine, it's called the Jynneos vaccine. It's available to anyone living, not just in Chicago, but anyone living in Illinois who has had close contact, skin-to-skin or intimate contact with someone diagnosed with MPV. Full stop, regardless of your demographics. To anyone, full stop, regardless of your demographics, who is living with HIV or is eligible for taking HIV PrEP. And this is because as we've learned more, we've seen that folks who have HIV are at higher risk for more serious outcomes related to MPV. So it's especially important that anybody living with HIV or at higher risk gets that MPV vaccine. And then anyone, regardless of demographics, who exchanges goods or services for sex. But also, anyone who is a sexually active, gay, bisexual, or other same-gender loving man, and anyone who is a transgender individual should get vaccinated. And then we've also seen, based on our data here, especially consider getting vaccinated if you meet those criteria and you've met recent partners through online applications or social media platforms like Grindr, Tinder, Scruff, or at clubs or raves or sex parties or saunas. Those are, when we look at our data, those are clear. Those activities do increase the risk right now for possible MPV acquisition. And then anybody who was diagnosed with any STI in the past 6 months, also strongly encourage you to please get that vaccine now. So lots more online. CDPH continues to offer MPV vaccinations for free, open to all, 6 days a week at our Lakeview, Austin, and Roseland locations. You can register at the website there or give us a call. And there are lots and lots and lots of places to get vaccinated across the city. And we would love to help get you or anybody you love connected. On COVID, the news is looking good here as well. In last week's Every week, the CDC does an update of how is the U.S. doing at a county level. We're down to just 27% of U.S. counties either at a high, marked in orange on the left, or a medium COVID community level, marked in yellow. Just 3% of counties, those orange spots on the left, are at a high level. And again, that's based on having especially a high number of hospitalizations. And then 23% of counties are in medium or yellow. All of Illinois, really pleased, for the first time going all the way back to May, all of Illinois is now at either a low or medium level. So if you look on the right there, most, including Chicago and suburban Cook, we are now in our second or third week in a row at that low COVID level. In Northeast Chicago, Lake County is just a little bit higher in a medium COVID level, but this is the setting in which we it is safer to not having to mask all the time, et cetera. Just as a reminder, this is the data that we use, that CDC uses to determine the community level, both for the city of Chicago and Cook County. And if either the city or Cook County data triggers the community level, we follow that. So the number that has kept us the most out of the low range historically has been this 8.7 here, because this is about hospitalizations. And the goal is to keep new hospital admissions under 10 per 100,000 over the last 7 days. And you can see we're now down to 8.7 at a county level, which is good. We're well under the metrics for cases, and we're well under the metrics for the percentage of inpatient beds that are occupied by COVID patients. So I love it when we're at a low level because it means the risk overall is not gone, but it's a point where it is safer to not have COVID top of mind. I also wanted to share, these are some of the additional COVID-19 indicators that the Chicago Department of Public Health follows every week. Our percent of emergency department encounters that have a COVID diagnosis, low concern is less than 3%. You can see we're just at 1.3%. We, as you know, do a lot of wastewater work. Low concern is when the risk of what we're seeing in wastewater has a score less than 2. We pull that together based on how many sites are seeing a certain amount of change, what are the concentrations, and right now our level there is 1.5, so that is also at a low risk. And then finally, we do a local assessment of what are we seeing in terms of variants. Are there new variants emerging quickly? Are there variants outcompeting others? And I'm happy that that also is at a low risk. So everything right now looking good on the COVID front here in Chicago. Reminder that at the low COVID community level, you got to stay up to date with your COVID-19 vaccine. And specifically, that means getting a vaccine this fall, in the fall of 2022. Get tested if you have symptoms. If you test positive, nothing changes in terms of isolation guidance, including wearing a face mask. And then obviously there are individuals, you should talk to your healthcare provider if you have an underlying condition. We are now seeing more settings that are mask optional. You may see signs like this: while this establishment no longer requires a mask to enter, please be kind to those who choose to wear a mask. I was on the L this morning, and I have to say, just over the last week or so, I commute by L every day, and just the last week, it has really felt like we're back to morning commutes in the ways that they felt more prior to COVID. This morning on the train, there were people, you can't get a seat. There's lots of folks in there. I definitely continue to mask in that setting, partly for COVID, partly for all of the other respiratory viruses I know are circulating, and because I see it as a way to care for others and limit that risk. But in terms of a formal requirement, when we are at a low level, individual settings can choose to make masks required, but in many settings they are more optional. But even when we're at low, regardless of your COVID community level, you need to mask if you have any symptoms of COVID-19. You think it's a cold, you think it's a flu, you're not sure, please put a mask on. You need to mask if you have a positive COVID test, and you need to mask if you've had recent exposure to someone with COVID. Nothing has changed there. If you catch COVID, you still need to stay home for 5 days at a minimum. If you're feeling better at day 5, you can be out in days 6 through 10, but you must mask in those public spaces. So nothing has changed and nothing will change, I think, in the short term on that guidance. Here's what the variants look like. It's still all Omicron and nearly all BA.4/5. So remember, the Omicron variant emerged last winter, the worst surge that we had. Everything basically has been Omicron for calendar year 2022, and the subvariants have continued to shift pretty quickly within that. But the new updated fall 2020 COVID vaccine is specific for Omicron. So unless you got a vaccine in September or October of 2022, there's a good chance that you do not have the best protection that you could have heading into fall and winter. If it's been less than 2 months since your most recent COVID vaccine, you're not due just yet. If you had COVID less than 3 months ago, you don't need to get that updated booster just yet. But for everybody else over the age of 12, you should get your fall COVID vaccine, just like you should get your flu vaccine. We're watching this BA.4.6. It's growing a little bit, up to about 10% of our cases. But getting folks vaccinated now is key. The patterns look similar across the U.S. We're up to about 22,000 Chicagoans under 5 have gotten at least a dose of the COVID vaccine. That's about 13.5%. Continues to be 2 to 3 times what we're seeing nationally, but I am not very confident that our littlest Chicagoans are as protected as they should be heading into what is already looking to be a bad respiratory season. We have a lot of kids in the ICU, in our children's hospitals, a lot of a lot of children right now, just with the regular childhood viruses, RSV, et cetera. When I think about adding flu and COVID on top of that, I am quite concerned. So please make sure your little ones get the vaccine. And then for the updated COVID vaccines, we did an analysis of the first 75,000 doses of the updated booster, the updated COVID vaccine that were administered to Chicagoans in the first weeks of the rollout. You can see we did our first 75,000 in the first about 2.5 weeks there. So through September 21. 75,000 is a small percentage of all of the people who are eligible in Chicago. We look at those first approximately 75,000. This is the demographics of who in Chicago were early adopters for that updated vaccine. You can see that about 21%, actually the largest group, have been people in their 30s in terms of numbers. Followed by, older Chicagoans, and 18 to 29-year-olds are lagging, and 12 to 17-year-olds really lagging. Just 2% of the vaccines administered in those first 75,000 went to 12 to 17-year-olds. And then on the right, if you look at race ethnicity, this I am the most concerned about, that about 63% of the first 75,000 doses went to white non-Latinx Chicagoans, about 14% to Black non-Latinx Chicagoans, and about 12% to Latino Chicagoans. And that is not because access is notably different. We've worked hard to make sure that in neighborhoods that are predominantly Black and Latinx, there are lots and lots of opportunities to be vaccinated. We've worked with pharmacies, we've got outreach, we've got literally dozens and dozens and dozens of sites in every ward, and we will bring this booster to your home. So this is less about the barriers, although there continue to be challenges, don't get me wrong, but it's about, do people have the confidence, is there prioritization, and do have people heard that they should be getting this updated vaccine? I see patients in clinic myself on Saturdays down in Little Village, and almost every patient that I am seeing there, I ask them if they're up to date with their COVID vaccine, and they say, of course I am. And I ask when their most recent COVID vaccine was, and often it was, back in April. And I'm on an individual level really having to educate folks that they should get that vaccine now, this fall. Almost everybody I see says, yes, they're happy to do it, but I'm still concerned that a lot of people don't realize that this is a different vaccine and that we really do want people protected heading into the fall and winter. Where you look and do some basic analysis in those first 75,000 doses, if we look at how many Chicagoans by race ethnicity are eligible for the boosters versus how many received them, again, just in the earliest uptake, only about 8% of white non-Latinx Chicagoans had gotten that vaccine in the first couple of weeks. About 4.5% of eligible Asian Chicagoans, about 2.6% of eligible Black Chicagoans, and just under 2% of eligible Latinx Chicagoans. So very long way to go. My goal is just to make sure Chicago is as protected as possible. The combo you don't want is COVID and flu, so get both vaccines. And all of CDPH's clinics and partner clinics, we always have the updated COVID vaccine, the fall 22 version, the flu vaccine, as well as if there are children who need earlier doses or adults who are just choosing to get COVID vaccine, we have it all available. This Saturday, for example, from 9 to 2, we'll be at Arturo Velasquez Westside Technical Institute and at Olive Harvey College. The COVID bivalent booster will be available, as well as all sorts of other types of vaccines. These are always free. We encourage people to register, but you can walk in. These are just to give you a sense through the end of October where our Saturday clinics are, partnering with city colleges. And then we've got sites with aldermanic organizations, community organizations, faith organizations, Department of Family and Support Services locations. Go to chicago.gov/vaxcalendar. And then likely coming soon, I don't have an update on this yet, but I wouldn't be surprised if this week we start to see the gears turning in terms of actual discussion from both the FDA and the CDC for approving the pediatric bivalent booster. So that means for 5 to 11-year-olds, they too will have access to the low-dose, updated COVID vaccine for fall of 2022. So these will be kid-sized doses, but they'll get the protection against Omicron as well. And I think that we may see authorization and a recommendation as soon as, early to mid-October. My guess would be sometime shortly after the Columbus Day holiday, we may have vaccine available. So again, I don't know this for sure. But it's based on conversations that we're hearing and the fact that both Pfizer and Moderna have submitted data for consideration, which would mean that children age 5 and up, not just children, anybody age 5 and up would be able to get an updated Pfizer vaccine, and anyone age 6 and up would be able to get an updated Moderna vaccine. So as always, you have any questions about vaccines or boosters, please visit us or give us a call 7 days a week, 312-746-4835. We will help you with whatever your needs are related to public health. So thank you. Let's go ahead and turn to some of your questions. All right. Rachel Sachs from Twitter says, thanks for the great panel discussion with Health News Illinois today. Thank you, Rachel. So for those, which would be most of you might not know, this morning I was really pleased to participate on a panel with Health News Illinois with Dr. Emily Landon from the University of Chicago, who has done so much related to infection control, has been an important voice for COVID in the provider community, has worked a lot with the state throughout the outbreak. She was on the panel along with me, and then my counterparts at the Cook County Department of Public Health, Dr. Lamar Hasbrook, who has been in that role now maybe for about 4 months, and then Dr. Samir Vora, the new director at the Illinois Department of Public Health, who has been in his role perhaps 2 to 3 months. He came in, that's the role that Dr. Ezike had previously. And it was actually the first time that we had an opportunity to all be together in person, although we talked to each other a lot. And it was a really good opportunity to talk about lessons learned from COVID. How do we think about being prepared as a city, a county, a state, healthcare systems for whatever is coming next with COVID? How do we think about funding, et cetera? So thanks to Health News Illinois. If you want to, check out the panel or see more, it was a really, I think, good conversation about important gaps that remain in things like funding and data access, and a conversation about what's worked, how do we still need to improve in terms of building trust, in terms of building capacity. All right, Faye State from Facebook. What medications are there for people who are COVID-19 positive, high risk for complication, and unable to swallow pills? So there are medications available. They are broadly what we call monoclonal antibodies. We use monoclonal antibodies which are injection or given through an IV. There's a few different versions of them. There's a version that we use called Evusheld that helps protect people who are immunocompromised that perhaps are not mounting a good immune response, and that really gives an additional level of protection. So for absolutely people who are immunocompromised, they still get vaccinated, but if we're not seeing for people who have underlying immune problems, if they're not mounting a good immune sort of response and protection, we will use antibodies to help prevent vaccine in those individuals, but also for people who, for whatever reason, not just that they can't swallow pills, but that they're unable to, perhaps they're on a medication that might interact with the oral medications that we use for people who have COVID-19. We can also use these antibody medications. And so always, 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 if you are diagnosed with COVID-19, I want you to let your doctor's office know that. If you don't have a primary care provider, you can give us a call, 312-746-4835. We'll help get you connected in. But I want to make sure that if you are diagnosed with COVID-19, whether you are up to date on your vaccines or not, whether you've never had a COVID vaccine, whether you've had every booster, I want to make sure that if you get COVID, you get access to the treatments that are our belt and suspenders approach. The belt, the vaccine, the most important thing in terms of protecting you against severe outcomes from COVID-19 and from infection. But also, if you get COVID, we've got suspenders too, and those are the medications that you have to take in the first 5 days of being diagnosed with COVID that can really help limit the chances that you're going to end up in the hospital or even potentially die from COVID. So I want everybody to let their doctor know, and then ask your doctor, do you think I'm a good candidate for treatment for COVID-19? For a lot of younger, healthier people, you may not need to take that medication, but for people with underlying conditions, it is absolutely appropriate. Someone already is asking, did you take this treatment when you got sick with COVID? So I did not, because I do not actually have any of the risk factors for a severe outcome from COVID. I don't meet the age recommendations, and I don't meet the underlying conditions for whom it is recommended. But I can tell you that I was watching my symptoms really carefully. I knew that I was completely up to date with my COVID vaccines. I knew that it was very unlikely that I was going to get seriously ill. But if I had not started feeling better by about day 3, I was absolutely planning to get the Paxlovid, which is the oral medication that you've got to start in the first 5 days. Because, even someone who was relatively high risk and up to date, if I was not starting to feel notably better, I was absolutely planning to start Paxlovid. And I will tell you that, when my parents had COVID, I made sure that they got Paxlovid. They, of course, were up to date with their vaccines. They did not get seriously ill. But that belt and suspenders is about making sure we are using what is available. And if someone is up to date with their vaccines, I really have low concern for them getting seriously ill. But the older folks are, the more underlying conditions they have, the more likely that is to potentially happen. And especially if there are folks who are not up to date with their vaccine, that treatment becomes increasingly available. So yes, if you can't swallow pills, or you have some other contraindication, you're on a medication that interacts, then talk to your doctor, and we want to make sure you get treatment. And that is true no matter who you are, no matter what your choices have been around vaccine to date. Okay. All right, Amanda DW on Facebook. I've heard the flu season is going to be awful. I remember hearing that potentially last year too. Do you agree? So, Amanda, I don't have a crystal ball. I don't completely know what this flu season is going to look like, but I am quite concerned about it. In fact, I am more concerned about it than I have been in either of the prior years. I think the first year of COVID, the first winter, our biggest concern was we know that flu is a huge strain on Chicago every year at baseline. We know that during flu season, we see, I mean, every year we have lots of Chicagoans get admitted to the hospital, get admitted to the ICU, and even die from influenza. And I think the biggest worry was, how will any surge in flu sit on top of a surge in COVID? We were learning a lot about how those diseases interact with each other. And I think we've not seen as significant of a flu surge as we might have either of these last 2 years. Frankly, I think because we still, we're learning how kind of flu and COVID work together, but also we were doing a lot of masking, a lot of extra precautions around COVID that spill over to flu protection that are not in place. The other reason is that the Southern Hemisphere is our best predictor of what the Northern Hemisphere is going to look like for flu season and respiratory season, because the seasons are backwards. So if I want to know what our winter might look like in terms of flu, the best place to look is the Southern Hemisphere's winter, our summer. And Australia has had a terrible flu season that they are just, coming out of now. Chile, some other countries in the Southern Hemisphere have had bad flu seasons. So I am concerned about flu for sure. And I'm concerned that particularly in the kids, where we had lots of masking going on previously, we weren't seeing a lot of the more routine childhood viruses at such high levels, and we are now seeing them now. That I do think there's a good chance that this will be, I would be shocked if this year we didn't have the worst flu season that we've had while COVID has been with us. And I don't know for sure what that will look like. Flu season has not kicked off in any serious way yet here in Chicago, thankfully. So getting that vaccine right now is what we want folks to do. It takes a couple of weeks for protection to start kicking in after you get a flu vaccine. So once flu is going strong here, yes, you can get a vaccine then, but it's better to have had that vaccine before we're seeing serious flu numbers. So I think, all I can do is look at the data and make my best educated guess. My best educated guess is that we are going to have more problems with influenza this winter in Chicago than we have had for the last couple of years. And I am concerned that our regular expected flu surge may also come on top of a COVID surge. The hope is that it will not be a crazy new variant. If we can get people vaccinated right now with the updated COVID vaccine that protects against the Omicron variants that are still what we're seeing, we will be in a much better place heading into the fall and winter. And it's always hard because it's difficult to estimate, how much doesn't happen as a result of people getting vaccinated, as a result of people wearing masks if we get into a surge, et cetera. I hope that I would be the happiest person alive if we get to February or March and we've seen nothing happen or very little happen on the COVID front. We've seen a very mild flu season. I would really feel more confident that we are even more past COVID as a society, whereas right now, I love that we're at a low COVID level. We should be celebrating that. Thank you for Chicago. But I am appropriately, I think, based on what we've learned about COVID, a little concerned about what we may see this fall and winter. And it is my job to make sure that you have that information and that we as a health department are being as prepared as we can be for potential surge. Dr. Shaw on Twitter, when do we get bivalents for our younger kids? Good question. So I referenced that right at the end. I do not have a date yet. I can tell you that it's been about a week since both Pfizer and Moderna have submitted, all of their data to the FDA. And I expect probably this week we may start to hear from the FDA whether that will be authorized. The data looks great. We have no safety concerns. The efficacy, because it's a better match for Omicron, all of the data suggests that the efficacy will be notably better. So I do expect a green light on that. But the FDA has to give it the green light first, and then the Advisory Committee on Immunization Practices, which are independent, pediatricians and other vaccine experts who advise the CDC, they need to weigh in, and then finally the CDC would have to give it the green light. We at the health department are planning tentatively to potentially have vaccine for children over the age of 5 available somewhere in the week of October 11th, 12th, 13th, which is really only about a week or a week and a half from now. But we cannot do that until we get the federal green light. So we've already done some of the pre-work with our pediatric providers, so we can pre-order and be able to place that vaccine very quickly with pediatricians. But I don't, I will be the first to share with you when we have formal knowledge. Watch the news. You will see, I think, the FDA, once the FDA gives it the green light, which I think will happen, then the CDC has to, and I think that will all happen probably with relative speed, given that we would like to be able to, as kids are getting their flu vaccines, we would really like to be able to get them their updated COVID vaccines at the same time. So we'll let you know, but my guess is mid-October, which is really just around the corner. Children over 5 will be able to get it, and right now, children over 12 can. Francie Swidler from Facebook. People I know are now getting COVID for the first time and feel unclear on what to do. Can you walk through the current protocols for what people should do if they test positive now? I know things have changed somewhat recently. Yes, this is why I kind of went over high level some of those slides about what has changed and what hasn't. If you are being diagnosed with COVID for the very first time, first of all, thank you. That means you have been extremely conscientious about protecting yourself and others. There are a vanishingly small number of people who have never seen COVID. There is almost nobody who has not. There's nobody really who at this point has not been vaccinated and has not had a COVID infection. It's part of why we're at a different stage here. But if you are getting diagnosed with COVID for the first time, first and foremost, you need to make sure that it is COVID. So you need to get tested. You can do an at-home test. You do not need to confirm that with going into a doctor's office or doing that formally. We treat any positive test as a positive. Those at-home tests, they are excellent for positive, especially. Where they can lag a little bit is on the negative side. If people develop COVID symptoms and they're taking an at-home COVID test, that can be negative, sometimes for 24, even 48 hours, especially if there's someone who's been vaccinated. It takes time for those viral levels to build up. So that's why we tell folks, if you have had a COVID exposure and you have symptoms, that is COVID until proven otherwise. You've got a mask. Think about staying home. But regardless, once you have a positive COVID diagnosis, you must stay home for a minimum of 5 days. Home. Isolated. Not spreading COVID. Those are the times you're the most likely to be spreading it. You then, if you are feeling better, days 6 through 10, you can be out and about as long as you're wearing a mask, and that means a mask in all settings. If you're not feeling really better, and there's some more details about that, you should just stay home until you're feeling better in that 6 to 10 day period. After 10 days, you are very likely to be potentially spreading COVID at that point, but we want you in touch with your doctor. Like I said, if it's your first COVID diagnosis, my guess is that you are somebody who has probably been quite careful about COVID, which means you may have underlying conditions, you may be older, or you may be caring for or in close contact with someone who has underlying conditions or is older. So I want you reaching out to your doctor, saying to your doctor, do you think I should get treatment for COVID-19? If your doctor, who knows your medical history, thinks that you should get treatment, for most people, that's a prescription that your doctor can usually do over the phone, that you can pick up at a pharmacy, et cetera, for Paxlovid. Paxlovid is the most commonly prescribed oral medication that you would take just for a few days, typically 5 days, that significantly cuts the level of COVID virus in your body, and can help make sure you don't develop more severe COVID. And then stay in touch with your medical provider. If you feel like you are not getting better after about day 5, you definitely need to be calling your doctor. And as always, if you're having trouble breathing, you're having chest pain, you're really not feeling well, we want you to go to the emergency department, because we can treat you in a way that we didn't have the tools to do at the beginning of COVID. So get up to date with your vaccine. If you're lucky enough to have gotten this far, not getting COVID, this updated booster is especially important because you'll get that booster against what's circulating right now. I was sort of, I got COVID for the first time when I went on vacation. That is often what happens when people are out of their routine. You do tend to interact with a lot more individuals. I was traveling with my extended family, and, we had a little mini, sharing of COVID. I'm thrilled I went. I have no regrets about it. But I think honestly, I got COVID in late August. Just 2 or 3 weeks later is when the updated vaccine became available. And if I had had the update, if that had already been available, I'm pretty confident that I probably would have continued to be able to avoid COVID. So that is the general protocol. Get tested. It can be at home. Reach out to your doctor to see if you should get treatment. It's too late to give you that Paxlovid. If you wait 10 days to call right away. And then finally, continue to follow the isolation and quarantine guidance. Stay home for 5 days. Let people who are in your close contacts, let them know you've just been diagnosed for COVID. They also should wear a mask for 10 days, and monitor themselves for symptoms, just in the off chance that you have inadvertently spread COVID. So let me know if you have more questions, but that is the basics. Get tested, get treated, get up to date with your vaccines, and let others know so that they can also protect and you can help stop the spread. Deb Billow from Facebook. At what point in time is the risk of getting COVID similar to the risk of getting the flu? This risk assessment is for a person who is all up to date with flu and COVID vaccines. That's an excellent question. I would put I want to complicate that question a little bit. The biggest difference between COVID and flu has been, it's not just the risk of do I get COVID or do I get flu? It's been the risk of do I get a viral infection that can make me seriously ill, can put me in the hospital, can potentially even kill me. And the problem is that COVID-19 has been dramatically more likely to cause those serious outcomes than flu. And so that is why COVID-19 remains in the top 5 things killing Americans and Chicagoans, in a way that influenza has not been in those top 5, causes of death for a while. So it's not just, is my risk the same? It's what is my risk of a severe outcome if I get COVID compared to if I get flu. Now that we have better vaccines, now that we have better treatments, now that we have better prophylactic antibodies, et cetera, for people with underlying conditions, the risk of severe illness from COVID is much lower. It's getting closer to where that flu risk is, but still a COVID diagnosis is more dangerous. The other point there is that COVID, different from flu, still in ways we do not fully understand. There are people, even who get mild COVID cases, who develop quote unquote long COVID. Clearly, there's something about COVID that in some people, their immune systems have trouble fully clearing it or knowing how to respond. And I also want people to recognize that the reason I care about you not getting COVID, first, I don't want you to go to the hospital. I don't want you to die. Second, I don't want you to get sick at all. That's not comfortable. And you have the potential to spread to others. But third, I want to limit the risk of you developing long COVID. And so I would say where I am looking at this fall, If you are fully up to date with your COVID vaccines and you are fully up to date with your flu vaccines, if you are someone who is not significantly immunocompromised and you are someone who, if you were to get COVID, you would reach out and get those early treatments that are available both for flu and for COVID, I do think that the risk for COVID is higher, but not dramatically higher than it may be for flu this season. But we're going to see how the winter goes, right? Last winter, Omicron came from left field and hit us in a way that I hope we never get hit again. And so, I'm sorry not to be able to just give you a straightforward, it's, this risk versus this risk, but if we are lucky enough not to see a new variant emerge, if we can stay at a low COVID community level overall, which I think is unlikely, but if we could do that, then I think COVID and flu start to look a little more like each other. But that's a lot of ifs. And I hope that that's, at least helpful for how we're thinking about it. I'm really curious to see how this winter goes. I would like nothing more than to see us not have any problems with COVID or flu. That would really be a good surprise. We're planning for that good surprise. We're also planning for the bad surprise. And at an individual level, you can help us be on the good surprise side, mostly by getting up to date with vaccine. If a person has this is Erica Salem on Facebook. If a person has a close contact who has COVID, is it reasonable for the person to work from home for 5 days if nothing requires him or her to be in the office? So it is certainly reasonable. Different employers have different policies around this. And I want to be really clear about this, that the most important, where nothing has changed, and I don't think it will change, in COVID guidance is around isolation, meaning if someone is diagnosed with COVID, they must stay home for 5 days. On quarantine, given that we have seen more breakthrough infections, even if folks have been vaccinated, et cetera, we do not make, at this point, the strong recommendation that individuals must stay home if they have been exposed. We do, if you have been exposed, you must wear a mask. And I think if you're able to, with your employer, work from home for a few days, that is certainly welcome, but it is not something that, different from a year or two ago, where if you were not up to date with your vaccine, we actually required quarantine. Quarantine means staying home if you're healthy, but you've been exposed. That, difference is no longer there. We instead have doubled down on making sure people are masking and making sure people are testing at the first sign of symptoms. And if they have a known exposure and symptoms, it's COVID until proven otherwise. All right, I think the last question, we're almost at time here, and I'm just looking at what else we didn't get to. I think I'll take Alexandria Dion from Facebook here. I know a lot of people who are sick but take an at-home test once and think they don't have COVID, which may not actually be the case. How many tests does someone need to take before they can be confident that what they have isn't COVID? That is a beautiful question. So again, I don't have a single answer. What I can say is that if you had a known recent COVID exposure, somebody in your family just had COVID, you had a close contact who had COVID, and you develop COVID symptoms in the next 10 days, you have COVID, almost certainly. And you should treat it like that, even if it takes a few days for the test to turn positive. For example, when I had recently been on vacation, I started testing right away when I came back, knowing that that had been a higher risk setting. I learned that one of my travel companions tested positive for COVID. I was feeling just fine. I took a COVID test. It was negative. I was being really careful about wearing a mask, which I would have done anyway for 10 days after vacation, but I didn't quarantine at that point. I didn't stay home. I was super careful with wearing my N95 mask. But as soon as symptoms, my very first symptom developed, just a little bit of feeling tired, a little bit of tickle in my throat, I was like, oh boy, I probably have COVID. I stayed home at that point. I took a COVID test, an at-home test. It was negative that night. I developed a fever. I was like, it's COVID. It was still negative the next morning. And then it took about, on my third COVID test, which was probably about 18 hours after my symptoms started, it turned positive. But I was working from home that day because I had symptoms and a known exposure, and I didn't want to expose folks. And then I stayed home for the 5 days. So, I think another option, might have been at that point the laboratory testing outside of homes, the PCR testing, is a little more sensitive. Usually it will turn positive a little faster, but please, especially if we're in a COVID surge, treat a positive test as a positive. If you've had a known exposure or you're having symptoms, it's COVID until proven otherwise. Wear a mask if you've had a recent exposure, and stay home if you think you may potentially have COVID. So I hope that helps think about it. I'm sorry that I don't have a really obvious, straightforward answer, but what I tell people is a negative at-home test is probably negative unless you're testing too early, meaning that the virus hasn't yet had a chance to build up in your body. The good news is when the virus hasn't had a chance to build up in your body, you're less likely to be spreading COVID yet. But nevertheless, it means that the test can stay negative. And this Omicron variant moves so fast that we are seeing sometimes people, it can take a day or two for those tests to turn positive. But I will take any positive, though, we don't see false positives on at-home tests, just to be clear. So any positive is a positive. Any negative is somewhat reassuring, but if you've had a known exposure or you have new symptoms, there's still a very good chance that it could be COVID. And if you take tests for a number of days, your symptoms are better, that's not COVID. But if you there's a good chance otherwise that your test may turn positive. All right. We are just a little bit over on time, so I'm going to have to call it a day. But thank you for your continued good questions. And some of the things that I didn't get a chance to answer today are actually on our website. Where we don't get questions answered, we will often either add them to the website or bring them back next week. So remember, next Tuesday, October 11th at 10 a.m., we're going to do a little bit of a focus on the public health budget for the city of Chicago, given that we'll be in budget season. So if you've got questions about what we do and how we spend money, that would be a great opportunity to bring those. We'll do a COVID update, of course, as well. And then on October 18, we will have a focus on environment because that's been an area of interest. So I look forward to your ongoing questions, and I really appreciate your attention and your ongoing interest. Please, please don't wait. Get your fall COVID vaccine now. Get your flu vaccine now. Be as protected as you can be, and help us keep COVID at a low level where it doesn't need to be top of mind, and we can talk about these other issues. Thanks so much. We will see you back next Tuesday at 11 a.m. Bye-bye.